Good morning, everyone. It is a profound honor to address this conference on the 40th anniversary of the Chernobyl catastrophe, an event that forever changed how the world understands nuclear risk and public health. I am Dr. Zhanat Kenbayeva from the WHO headquarters in Geneva, and I'm joined by Dr. Kamal Akbarov from our country office in Kiev. In this talk, we explore how Chernobyl's hard-won lessons continue to shape global preparedness for radiological and nuclear emergencies today, with the focus on human health, of course. Let me share my screen. And without any delay to start the presentation, I will switch to the full screen mode. I hope you can see it. Here we go. So the topic of the presentation is the role of Chernobyl experience in advancing global preparedness and response to radiation emergencies. And I would like to sincerely thank the organizer of this conference, our long-term collaborators, REMPAN Collaborating Center in Ukraine, at the National Research Center for Radiation Medicine and Oncology and Hematology, and personally, doctors Dmitry Bazika and Anatoly Chumak and Natalia Korol and Valentina Vasilenko and many other collaborators with whom we've been working now for more than 2 decades on various activities. Let us begin with setting the context, because to understand where we are today, we must understand the world in 1986. The accident was not simply a nuclear disaster. It was a transformative event that sent shock waves through public health, environment, economics, and the social fabric of entire nations. What followed was a continuous evolution of global frameworks, shaped first by Chernobyl, then refined after 9/11, Fukushima, COVID-19, and now by concerns about military threats to nuclear infrastructure. Each crisis taught us something new about preparedness. This is the story of that evolution and of how Chernobyl remains at its very foundation. The first and perhaps most immediate institutional response came in the form of 2 landmark international conventions adopted within months of the accident. Within the same year as the accident, 1986, the international community recognized that nuclear emergencies now know no borders. 2 conventions were born from this recognition. The Early Notification Convention established a binding obligation for rapid cross-border alerting, so that neighboring states would never again be left in the dark about nuclear event on their doorstep. The Assistance Convention created a coordinated framework for deploying medical and technical expertise across borders. Together, these 2 instruments fundamentally transformed the global radiation emergency architecture, and both of them are managed by the Secretariat at the International Atomic Energy Agency. These 2 conventions did not stand alone. They became the foundation for the entire international system led by IAEA and involving WHO and many other international organizations. Under IAEA leadership, the international preparedness and response system grew to encompass more than 20 other organizations, all operating under a joint plan that defines responsibilities and operational protocols with clarity. WHO is a full party to both conventions and an active member of IACRANA committee, ensuring health protection sits at the center of every international emergency response. This multilateral architecture is one of the direct Chernobyl's most enduring legacies. WHO's own operational response to Chernobyl lesson took shape in 1987 with the creation of a global network that has grown into a truly global resource. REMPAN, the Radiation Emergency Medical Preparedness and Assistance Network, was established just a year after the accident. Starting with only 4 member institutions, it has grown into the largest global expert network of its kind. REMPAN provides training, policy advice, and direct emergency medical assistance to countries worldwide. Its meeting locations from Buenos Aires to Nagasaki and Germany, Geneva, Seoul last meeting in 2023 reflects its genuinely global outreach. This network is WHO's primary vehicle for translating Chernobyl lessons into operational capacity around the world. If the institutional response to Chernobyl was the first major lesson, the communication failures of 1986 taught us something equally critical, perhaps even more so for public trust. In 1987, Soviet authorities delayed disclosure for days. The result was not safety, it was a mass panic, deep mistrust, and a vacuum quickly filled by rumors and misinformation. Today, transparent and timely public communication is considered a non-negotiable pillar of emergency response, as important as the medical response itself. WHO developed risk communication frameworks, including tools for managing infodemic, that are now embedded in national health emergency response plans worldwide. The lesson is clear. You cannot protect public health while withholding information from the public. One of the most tragic and instructive health consequences of Chernobyl was the surge in childhood thyroid cancer, a story of contaminated food, delayed action, and a lesson now central to global preparedness. Contaminated milk and food products led to widespread radioactive iodine exposure, particularly among children. The result was a dramatic surge in childhood thyroid cancer, entirely preventable with timely intervention. Iodine thyroid blocking, the use of potassium iodide tablets, is now a cornerstone of radiation emergency planning globally. Pre-distribution of KI tablets is a standard recommendation in WHO and IAEA safety guides and guidelines. This single lesson from Chernobyl has the potential to prevent thousands of cancers in any future radiation emergency. The thyroid cancer experience pointed to a broader truth that some populations are disproportionately harmed in radiation emergencies, and response planning must reflect this reality. Children faced up to 10 times higher rates of thyroid cancer compared to adults, a consequence of their smaller thyroid glands and high dairy consumption. This finding transformed how we think about vulnerability today. Pregnant and lactating women, evacuees, and displaced persons each face specific risks that now have dedicated protocols and international guidelines covering evacuation priority, potassium iodide distribution, and long-term psychosocial support. Chernobyl experience led to establishing vulnerability-based prioritization as one of the fundamental principles of radiation emergency planning. While civilian population bore enormous suffering, more than 600,000 cleanup workers or liquidators faced some of the most extreme exposures, with consequences that shaped international worker protection standards. Many liquidators worked with little or no dosimetry in the early stages, wearing inadequate protective equipment and receiving no clear limit of cumulative dose. The long-term consequences, such as cancer, cataracts, cardiovascular disease, and psychosocial impact, have been well documented. In response, international norms were revised. Mandatory individual dosimetry, real-time dose tracking, standardized protective equipment, and worker rotation schedules are now fundamental requirements in radiation emergency operations. The liquidator's sacrifice became the foundation of modern emergency worker protection. Perhaps nowhere is Chernobyl's direct impact on medical science was more visible than in the evolution of management of acute radiation syndrome. where 134 confirmed cases drove an evidence-based evolution in treatment. Initial attempts at bone marrow transplantation proved largely unsuccessful, unfortunately, prompting a critical shift towards cytokine therapy, growth factor support, and comprehensive supportive care protocols. These protocols used today in any radiation emergency, they trace directly back to the clinical experience of 1986. This evidence-based evolution of how the global standard shifted for the acute radiation syndrome management is reflected in the recent publication of WHO policy on setting up national stockpiles for radiation emergencies. It provides detailed formulary, including that for the management of ARS. It can be downloaded in several languages. And we thank WHO collaborating centers in Nagasaki, in Japan, and Kiev, in Ukraine, for supporting the translation of this document to Ukrainian language as well. Beyond those treated directly for radiation injuries, Chernobyl created an urgent need to track exposed populations for lifetime, and in doing so, established the global model for post-emergency health surveillance. Ukraine, Belarus, and Russia established national registries tracking liquidators, evacuees, and other exposed communities. Decades of epidemiological data from these registries have informed global radiation risk models used to set exposure standards worldwide. WHO coordinated several international programs such as IFECA in early 90s, Chernobyl Forum in 2000s, producing authoritative assessments that contribute to the guide international policies. Long-term health surveillance after radiation emergencies is now a mandatory component of WHO emergency response frameworks. This is a direct legacy of 1986. The physical health consequences of Chernobyl have been widely studied, but psychosocial dimension proved equally profound, and it was actually recognized as the largest health impact of the Chernobyl catastrophe. It took longer for the international community to fully recognize this. Fear, stigma, displacement, and loss of community identity affected hundreds of thousands of people for decades. Elevated rates of depression, anxiety, and post-traumatic syndrome were documented long after the acute emergency has passed. Ukraine had since developed a dedicated social support programs, mental health services for evacuees and first responders, and community resilience initiatives, many of which serve as models for other affected countries. The key lesson here is that psychosocial support is not supplementary to emergency response. It is an integral part of it. Chernobyl also transformed the relationship between governments and civil society, a dimension of preparedness that is sometimes overlooked but proved vital in the aftermath of the accident. The secrecy of 1986 created a vacuum that civil society organizations, NGOs, advocacy groups, citizen monitoring initiatives, and activists stepped into to fill. Their role in providing humanitarian aid, health monitoring, and community support proved very important. WHO and IAEA frameworks today formally incorporate civil society consultations in emergency planning. Independent oversight mechanisms have been strengthened globally as a direct result of Chernobyl experience. Effective radiation emergency response requires active community engagement and not only of governmental institutions. Let me now bring these threads together, because Chernobyl's legacy is not a collection of isolated lessons, but 5 interconnected pillars that form the architecture of modern radiation emergency preparedness. These pillars include international conventions, global cooperation and coordination, also protective actions including potassium iodine distribution, including food and drinking water safety monitoring and safety standards and other urgent protective actions. Also, the clinical management of acute radiation syndrome has now evidence-based cytokine therapy protocols. And finally, psychosocial dimensions of consequences of nuclear emergencies. It is a recognition that mental health is critical to emergency response and should be addressed already at the planning stage. The most powerful test of any preparedness frameworks is whether it performs when the next emergency arrives. The tragic triple disaster in Japan in 2011 provided exactly that test. The comparison is actually striking. Where Chernobyl saw delayed KI response, Fukushima deployed national stockpiles rapidly. Where 1986 saw international notification failures, 2011 saw IAEAs being notified within hours. Where 1986 created registries retrospectively, Fukushima launched its health management survey within first months after the accident. Fukushima proved that frameworks built on Chernobyl experience save lives, but it also revealed new gaps, particularly around evacuation decision-making, on children thyroid screening, and long-term environmental mitigation. These are lessons that continue to refine global EPR strategies today. Preparedness is not a destination. It is a continuous journey of learning process. Which brings me to our conclusions and to the fundamental message I hope you will carry with you from this session. Chernobyl was a defining event in radiation emergency medicine. Its lessons from KI prophylaxis to risk communication to civil society engagement and management of psychosocial impact continue to guide WHO and its partners 40 years on. Fukushima confirmed that these lessons are not historical artifacts. They are living frameworks that protect people today and will protect people in future emergencies, which we cannot yet foresee. As we mark this 40th anniversary here in Kiev, let us honor the experience of those affected by reaffirming our commitment. The work of preparedness is never finished. Each emergency teaches us to do better, and we owe it to future generations to keep learning. With that, I will conclude my presentation, and thank you once more again for giving WHO the opportunity to present this talk. Thank you very much.